Hi, welcome back on Iron's Health Talk with Dr. Akram. Today we're talking about vascular disease, and first half we talked about varicose veins, how it develops and what we could do, a little bit about prevention and the treatment. And second bit we're going to concentrate on aortic aneurysm. This is quite important. This is a disease. This can kill a lot of people if you don't know how to diagnose it, if you don't get specially medical help straight away. And on our show we have two special guests. It's Daniel Dobes, and he's a vascular surgeon, and Mr. Ahmed Abidia, and he's also a vascular surgeon in Essex, and they both work in the field. And if anyone join, please be with us, and let's play a video and say what we're going to talk about.
Perform an abdominal aortic aneurysm repair to prevent the rupture of a bulging area of your aorta. The largest artery in the body is the aorta, which is attached to the heart and receives blood directly from the left ventricle, or main pumping chamber. The aorta is divided into four parts: the ascending aorta, aortic arch, thoracic aorta, and the abdominal aorta. The abdominal aorta is the last and largest section of the aorta. It supplies blood to the lower regions of your body, including the organs in the abdomen and pelvis. The abdominal aorta ends around navel level, where it splits into the two iliac arteries that carry blood to the legs. The aorta has a thick wall so it can withstand the high pressure of blood being pumped from the heart. Over time, the wall of the aorta may weaken, slowly bulging outward like a balloon. When this condition occurs in the abdominal region, it is called an abdominal aortic aneurysm.
Ahmed, let's talk a little bit about aortic aneurysm.
Aneurysms, just to make it clear to your viewers, is when the artery becomes weak and the supporting layers that keep the artery in the correct size can't stand the pressure inside the arteries. It starts to give way. So it's what we call a degenerative disease, like wear and tear, where the collagen, the supporting tissues are in the arteries.
So that's for any artery can develop an
That can happen in
yeah.
any arteries, and many of you viewers would be aware of like aneurysms that occur in the brain, which is another silent killer. So patients with aneurysms may not know that there is an aneurysm,
they have an aneurysm,
and then suddenly it bursts and it bleeds, and unless they have timely intervention to seal off the burst artery, they'll end up in a catastrophe. The commonest location for aneurysms is the abdominal aorta.
Abdominal aorta, isn't it? I'm going to hold you there. Daniel, would you mind showing the abdominal aorta in our Iron Man, who is specially waiting for that part?
Yeah, we are talking about this region here. This aorta should be abdomen. This part of aorta is mostly dilated directly in this place.
Okay, excellent. So please go ahead.
So 80% of aneurysms in the aorta occurs in that location where Daniel pointed at below, where the artery, the aorta gives rise to the renal arteries, the kidneys arteries. And that's very important because that's very accessible surgically to repair when the need arises. Other location for aneurysms would be where it splits into the two divisions.
Two divisions, is where it, kind of where it goes to each leg, isn't
Exactly, exactly.
All right.
And then another common location is behind the knees. It's called the popliteal
aneurysm. That's exactly behind the knees.
Yeah.
Okay, Daniel, would you mind showing that the place where it divides into both legs?
Yeah, the division of the aorta is directly here. We call it bifurcation.
Okay.
It's not marked on the right side, but it's clearly visible on the left side. It's like reverse V here on both sides. Directly is the division here.
Excellent. And the other one is just behind the knee, isn't it?
Yeah, I can show you mostly the area when we can expect the aneurysm is directly behind the knee, is the red
And
structure here, which is artery and can be dilated directly in this region.
excellent.
No.
So,
Aneurysms, when they burst, they can be fatal. And the idea is to pick them up earlier on.
first
They
of all,
affect
I'm going to
about
ask,
1% of
why does
peop-
this aneurysm develop? I think we showed in our video, but can you say a little bit about how does it, why does it develop?
The commonest reason for aneurysms to develop is atherosclerosis, which is hardening of the arteries.
Hardening of the
it's-
arteries, isn't it?
So it cuts off the blood supply to the arterial wall, and then that becomes weaker and weaker, and eventually.
So that's a good point, because all this muck, sorry for the word, which comes inside the arterial wall,
Yes.
that stops the blood supply to the wall
To the
itself.
wall, yeah, and then it becomes weaker, and it
Weaker,
starts giving way. But there are other causes for aneurysms. So the atherosclerotic aneurysm, which I mentioned, tends to happen at older age, and patients tend to have been smokers
Smoking is one of those.
for many years. So that's a big risk factor for aneurysms developing. But there's another group of patients who will develop aneurysms, and those are people who have disorders of the connective tissue. So people with conditions like Marfan's syndrome, where the connective tissue is abnormal, they can develop aneurysms. And there are other rare conditions like Ehlers-Danlos syndrome, which is also a connective tissue problem, where it becomes weak and causes aneurysms. And finally, there are a group of conditions called vasculitis, which are also under the umbrella of autoimmune diseases, and they can give rise to aneurysms. So the Marfan's and the vasculitic aneurysms, they can occur at younger ages. So we see people in their 30s, for example, or late 20s with aneurysms developing, while the atherosclerotic aneurysm, the hardening of the arteries one, that tends to occur later in life. So people usually are like 60 and above when they develop those aneurysms.
So smoking is one of the major contributory factors.
Critical for the atherosclerotic aneurysms. It's one of the most critical risk factors.
Because when we think about smoking, we never think about the arteries, and we always think about lungs and lung cancer, all of the funny things, isn't it?
Absolutely, and I think what we're hoping is with improved awareness of the risk of smoking and people smoking less than they used to in the past, that future generations will have lower risk of developing aneurysms. I think we're already seeing that. I think the incidence of aneurysms compared to like 20 years ago have reduced. Having said that, there's still about 1% of people dying in the UK are dying from aneurysms. So it's still a significant number of people dying from aneurysms.
That's right. Oh, actually, we have. I think when we had this COVID, it was in full-blown COVID times in January or February. We were operating on an aneurysm, isn't it?
Daniel repaired the
Daniel, yes.
Yeah, that's always it's important to say that if we have a chance to operate the aneurysm electively, to plan and prepare everything, it's much better with better outcomes. If the aneurysm became symptomatic or with the rupture with the risk of bleeding, then the operation is very risky for the patient life.
Once it ruptures.
Yeah, and it's life-threatening operation, is no doubt, especially if we have a picture of patient with comorbidities and rupture aneurysm, there is a high risk of bleeding and lost a lot of blood. Is always such a difficult part of vascular surgery.
What kind of mortality or like a possibility of dying of this aneurysm if it's ruptured?
If there's a rupture, the mortality is high. It can be from 60 to 90%.
60 to 90%. So possibly about 10% of them will survive.
If the patient is with right diagnostic in time and is relatively fit, then we have a chance to start with urgent procedure as soon as possible. Then we have the best chance to save the patient life. If the patient is with delay, with a lot of comorbidities, mostly it's difficult to offer the patient such a successful treatment.
Daniel, I see this is aorta is one of the major arteries pumping out from the heart almost straight away. It's like the major tap out of this this reservoir. So
Yeah.
if it leaks, it will leak all the blood within short time, isn't it?
Yeah, if there's a bleeding to open space, then is a bleeding for 1 minute and we have no blood, because the 1 minute is the circulation, whole circulation volume is running into this highway of blood. But we have a so-called retroperitoneal space. You can tamponade
So
the bleeding a
luckily-
little bit. Then we have a, we call it treatment window to do something.
Yeah.
If there's a rupture to abdomen, like a area where our intestines, mostly is difficult to save patient.
That's because there is a kind of septum or something which holds the artery
Yeah,
behind,
it's some
isn't it?
light septum there,
Yeah.
but it can hold some pressure only
Some
for
pressure.
a while, not
So
for a long
The
time.
blood which leaked will clog there and
And tamponade the tear from the aneurysm.
aneurysm.
And then we have a time to do for urgent theater,
Yeah.
organize everything quickly, and then we have a chance to save patient life.
So that's the time our blood pressure goes up, isn't it?
Yeah, definitely. It's such such a stressful procedure,
Stressful
no doubt,
procedure.
because we have to find the right place, avoid further bleeding, stop the flow there, and quickly provide the replacement of the
And you
aorta.
shout at the anesthetists shout back at you.
Yeah, it's not going this direction. I think that we are calm, but we need to run as a one team
One team.
quickly.
Excellent.
And my such experience is that anesthetists should run with us maybe one step before.
But actually we are fighting to save a life there. That's the important thing, isn't it? Because we are all in stress and we need to get that patient under the table and operated so that patient can be alive. Okay, can you tell a little bit about the signs and symptoms of
Yeah, I
aneurysm?
think
First of all, you could say if it's not ruptured or if it's ruptured and
Yeah.
how it happens.
I think it's important to say, it was mentioned previously by my colleague, is something like silent killer, because the growing can be in place for many years, 5-10 years easily, and without any symptoms, any pain, anything. And first symptom can be the rupture, which is presented with severe lower back pain, which is spreading to abdomen.
Lower back pain.
Yeah. And to both legs. It's mostly together with drop of the pressure, sickness of the patient.
So if you are a patient, you would feel the lower back pain, which is the pain going to your legs and back. And what else will you feel? Dizzy, sickness?
There is a
vomiting,
sickness, but the pain is severe because you feel the expansion in this area which is close the spine. Therefore, the symptoms are mostly similar like the problem with spine or with kidneys.
Kidneys, right.
But mostly these symptoms involving kidneys or spine are not together with important drop of the pressure. Some unconscious can be in place for a while, and patient can be back within 30 seconds, 1 minute, with low pressure. But if you have the symptoms, important to keep the pressure low and find the vascular center to organize urgent procedure to save the patient.
So if someone at home feel this kind of symptoms, there's no time to make a coffee, isn't it? So
Definitely is to call ambulance with blue lights, and they need to recognize symptoms early to send the patient to right place, to arrange CT angiogram to clarify the diagnosis and organize urgent procedure.
So before it ruptures, will it give any kind of clues? Hey, I'm there, I'm growing.
Yeah, very rarely, if we call it like a symptomatic aneurysm, can be some non-specific back or abdominal pain. And mostly then we can find the aneurysm as a big one causing some pressure source of this area, which is then symptomatic. But what is common, the patient is sent for different type of scan, and then we have an incidental finding of enlargement aorta, and patients are surprised they have some pathology involving main blood vessel.
Okay, Ahmed, let's talk a little bit about when to get help, when to go to A&E, a little bit of screening.
The point to emphasize here, it's prevention is better than cure. So waiting until it ruptures is waiting too late. To put it in simple numbers, for people who have a ruptured aneurysm, half of them will not make it to the hospital. Half of them will die at home or on their journey to the hospital. And then of those who make it to the hospital, half of them will not survive the actual operation. So it's a very high risk condition with a very significant mortality. So it's key that we recognize and identify the aneurysm well before it ruptures, so we can provide the operation and prevent the rupture from happening. And as part of this, as Daniel mentioned earlier, there's people get identified while they're having a scan for a different reason, and then the aneurysm is picked up, and then that usually raises the red alarm bells in with the person reporting the aneurysm, and the patient gets directed to the vascular surgeon to be dealt with. However, there is a national screening program which has been introduced, and people who are when they get to their 60s.
When they go to the 60s?
They get invited for an ultrasound scan. So this is a national program. At the moment, it's only for men, because this condition tends to affect men more than women.
That's right, yeah.
So although maybe 1 in 4 aneurysms will be in females, but from a national point of view, they look at cost effectiveness, and if they were to screen the whole of the population, they will be the cost benefit would be minimum. So the Department of Health introduced a screening of males when they get to their 60s to identify those aneurysms, and then once they picked up, they get referred to the vascular units to be treated. In terms of general prevention, I think the main emphasis is to not smoke, and if you're a smoker, to stop smoking, because this is one factor that puts you at significant risk of developing aneurysms. But in addition to that, it will put the patient at risk of other conditions, like you mentioned earlier, the lung cancer and the lung problems that come with it, heart attacks, strokes. So it's a very serious problem from when it comes to the health.
So the smoking is I think it's something like an old diesel engine which is coughing a lot of smoke, and the exhaust pipe, it just sediments there. Is something like that?
It's a very good analogy, a very good description of what smoking does to the patients. I think there's a very tiny number of people who will smoke and not develop any of these diseases. And I think
we don't know who it is.
We don't know who it is exactly, and I don't think anyone should take any false sense of security having seen somebody who lived to their 80s, smoked all their lives and didn't develop any of those problems, because those are the minority rather than the majority.
Actually, while we're talking about, I'm actually planning 2 programs on smoking. There'll be one special on smoking where we're going to consider smoking and its all problem related to it, and there's another program I'm planning to do with my 2 specialists here, smoking and vascular problems, and a lot of people had lost their legs because of smoking, isn't it?
Yeah,
this is something
true.
Not many people know about it. So we will plan this talk probably in a few weeks or a few months or something like that. But that's on the loophole. Anyway, okay, let's play a video and let's see what we can do for these aneurysms.
Perform an open abdominal aortic aneurysm repair when the diameter of your aorta exceeds 2 inches. Or if you're having symptoms such as intense abdominal pain or an abnormally prominent abdominal pulsation. Before the open procedure, an IV line will be started to provide you with fluids, antibiotics, and anesthesia. A traditional open surgical repair is performed under general anesthesia, which means you will be asleep for the duration of the procedure. A breathing tube will be inserted through your mouth and into your windpipe to help you breathe during the operation. When you are asleep, a catheter will be inserted into your bladder to drain your urine and monitor your kidney function. Your surgeon will begin by making an incision from the breastbone to below the navel. He or she will then locate the aneurysm and clamp the aorta just above and below it. Your surgeon will then open the aneurysm and sew an artificial graft, the same size and shape as a healthy aorta, into place. Your surgeon will stitch the wall of the aneurysm closed over the newly placed graft. The graft will reinforce the walls of the aorta. Your surgeon will close the abdominal incision with stitches. A catheter or hollow tube will be passed over the guide wire and pushed toward your aneurysm. Using live X-ray pictures as a guide, your surgeon will pass an endovascular stent graft, a compressed fabric and metal tube, through the catheter to the aneurysm. Then he or she will open the graft, which will be held in place with metallic hooks and stents. Your surgeon may insert additional graft components to extend the graft into the blood vessels supplying your legs. Once the graft is in place, your blood will flow through it, not into the surrounding aneurysm sac, which will remove the pressure from your aneurysm. Finally, your surgeon will remove the catheters and close the incisions in your groin. The procedure will generally take 2 to 3 hours.
Shall we explain it in simple format what we showed in the video? Can you say what are these?
Yeah, we have two options. One is to provide open surgery, to provide a suture and replace the part where is the aneurysm by artificial tube. The second option is to insert such a so-called device, stent graft, which means to insert the tube without suture and exclude the aneurysm from the flow. The main difference is that when we provide a suture, the artificial tube is fixed there. But when we insert the stent graft there, it needs to be in position by tension, which is holding from inside. There is no suture.
So for the open aneurysm, can you show in our Iron Man what you do roughly?
Yeah, if we're doing open surgery, we need to open the area there, put a clamp in this area and stop the flow from half of the body and do the suture.
So you need to open into abdomen,
yeah,
so you need to go through the abdominal wall.
By incision from here up to here,
yeah,
and to provide exposure of this part of aorta, which is deep part of abdomen.
Yeah.
And we put a clamp here, open the area and provide a suture this and here up to here. Sometimes we have to extend it up to iliac arteries and main pelvic area arteries, or sometimes up to groin.
Okay, so that's one option, and the other one is endovascular EVAR.
Yeah.
Where do you insert that probe? From where? Can you show us in the?
We have to insert the probe through the arteries from the groin area here, and both sides. We call it bifurcated graft because we have a main part of the graft and bifurcate it into each pelvic artery.
And you pass this graft and you send some kind of a metallic.
Yeah, it's like net tube.
It's
which is
net
covered.
tube.
Yeah, it's in so-called nitinol, is a special wire, which has a memory to be inserted from the small tube and to have a good shape of the area. And it's important to say that we have to provide the procedure under X-ray control because we don't have an exposure of this area here. We see the device on the X-ray, see the right position, and then we provide the deployment, and we check there is a good flow and aneurysm is excluded. It's important to say that we need to have a good shape and we need to have important zones as a neck of aneurysm, which is the distance between the beginning of stent graft and kidney arteries. It means there's an important sealing zone to have a good flow in the stent grafts only and exclude the aneurysm from the flow.
Excellent. Gentlemen, it's my pleasure to have you both here. We had a great talk and we have given what we could about two conditions, the varicose veins and aneurysm, which is two most important. Thank you very much for being with us, Daniel and Ahmed. It's our pleasure, and hope to see you again in similar programs. For being with us, for my viewers, it's a great show, and today we talked about this vascular disease, and initially we talked about varicose veins, and then we talked about the aneurysm. So far we have run out of time. We couldn't talk much. I wish we had more time, but anyway, thank you for being with us. So thank you for staying with us in Iron's Health Talk with Dr. Akram. If you have any further questions, please email us on healthtalk@intv.co.uk. Message us on Facebook, Twitter, and we will respond as soon as we can. But for now, goodbye and keep yourself safe.
Good night.